Please welcome Stanley John.
Thank you. I just forgot my pants, but it's all good. Okay. Well, thank you very much. Al, thank you for the introduction. Can you guys hear me? Yeah? Yeah? Okay. So, yes, my most important job is working for AQ Seminars. Just so you know, I still haven't got my check from the last 2 seminars. So put it out there. Okay, so anyway, welcome back from IHOP, right? The mini IHOP that's happening over there. I think that's something new. I never had pancakes. It was always something like muffins and bagels and sandwiches, but hot pancakes, that's a great addition. So before we get into the lecture, just a disclosure. I have no actual or potential conflict of interest, so if I do mention a product, any brand, or refer to any articles, I do not get any kickback, right? So it's purely for informational and educational purposes only, all right? So hope you guys have a good time. So what's the objective? For today's lecture, the objective is understanding ECMO, right? How it works, the evolution, the history, the type of ECMO, what are the indications, contraindications, and as respiratory therapists, how are we involved with ECMO? So again, you will not see a lot of conversation or slides on how to manage the ECMO device itself for a couple of reasons. One, we'll talk about it. One, from a New York State perspective, or from New York State, we do not have any RTs who are physically managing ECMO machines at this time. We do assist. In some institutions, we're part of the team, but physically there's no one who's managing right now. So we do manage as far as maybe priming the machine, in some cases maybe managing the ventilator, but hopefully down the road you'll be seeing a lot more involvement of respiratory therapists and management in ECMO. So we have another presentation for individuals who are in a role where they work, either they're respiratory therapists and they work in a perfusion kind of setting, or a perfusionist who needs to understand a lot more on how ventilators interact with ECMO machines. We have another presentation on that where we go very in detail and in depth. So that's not the lecture today, but it's going to give you a basic overview of what ECMO and things like that is. So ECMO pretty much stands for extracorporeal membrane oxygenation. So you break it down, simple terminology. Pretty much you take deoxygenated blood outside the body, right? So that's where you get the extracorporeal terminology, and then you circulate it through a filtration pump and an oxygenator, which acts as a membrane, very similar to our AC membrane. And at that point, what it does is you take out the CO2 and you add O2, and then you reintroduce it back into your systemic circulation. So pretty much that's the whole concept, right? So pretty much what your lung is doing is what you're doing outside of the body. And in certain cases, we'll talk about in the next few slides, whether it's strictly pulmonary or is it cardiac or it's a mix of both. So fundamentally, so we know that, okay, that's what it does, right? So the machine takes it out, takes the deoxygenated blood, takes the CO2, puts O2, and puts it back in your body. But what's the rationale behind that? So the fundamental whole thing about ECMO is it provides a temporary support. So that's a key word, right? It's a temporary bridge or a temporary support to assist the normal function of whether your lungs or your heart, to return to its normalcy. That's the whole point of this. So again, it's not a long-term support. Is very temporary. So you probably have days or maybe weeks. I think when we look at literature, I think the longest one was about 2 months, and that was it. So we're not talking about 3-4 months. So the concept of long-term patients on ventilators and long-term patients on ECMO is 2 different things. So it's much shorter. Okay, so that's what it is. It's a bridge. It's temporary, and it's for short-term use. So what happens? So when your body is resting, or in other words, when the work is done outside of your body, it gives your organs, whether your lung or your heart, to rest and heal. That's one thing. And second, it pretty much prevents further damage, right? Due to stress injury, due to a lot of things that we do on the mechanical ventilator. So whether that is, can we decrease the FiO2? Absolutely. Can we use adjunct therapies like nitric oxide, things like that? Absolutely. Can we lower the pressures on the ventilator? For sure. So that's just from the respiratory perspective. Then you have sedation. Can you wean off sedation? Yes. Can you take patients of heparin and things like that? So there's a whole lot of things that you can minimize, which your physical body doesn't have to go through, and it gives your body the time to rest and heal, and then when that's done, you pretty much replace. In other words, you put the patient back on what it needs to be. So again, temporary support, you're buying time, right? So these are the two important concepts, and that's how it works. So I'm going to show you a video. So you're not going to understand much from it, but it's a very cool video, and I think the animations are pretty good on this one.
Saving a life is no easy task. Options for treatment vary based on the severity of injury, the prior health of the patient, the experience of the medical team, and the resources available within the hospital. For over 60 years, doctors relied on ventilators to supply oxygen and remove carbon dioxide when a patient's lungs or respiratory system fail. Ventilators oxygenate the body by forcing air into the lungs through a tube inserted into the trachea. As the ventilator pumps air into the body, the lungs inflate to mimic the process of breathing. When the ventilator finishes delivering a breath and the airway pressure drops, air is exhaled from the body and the lungs deflate. While this mechanical imitation of breathing can achieve the same goals as spontaneous breathing, it is not natural to our bodies and has its own side effects, especially at high pressures and oxygen concentrations. Although doctors don't exactly know at what settings a ventilator's side effects start to cause lung damage, they do know that an alternative treatment called ECMO can reduce injury caused by ventilators and foster lung healing in certain types of diseases. ECMO stands for Extracorporeal Membrane Oxygenation, and it can carry out the work of a patient's lungs, heart, or entire cardiorespiratory system following trauma, infection, or surgery. It works by removing blood from the patient's body, pumping it through an artificial lung where it receives high concentrations of oxygen and carbon dioxide is removed before returning it back to the body. This technology sounds simple in concept. However, it is actually an intricate system that requires a team of specialists to watch over an ECMO response 24 hours per day, sometimes for several weeks. As with most life-saving techniques, ECMO and ventilators each come with pros and cons. Mechanical ventilation is a quicker method for oxygenating a patient. Standard ventilation requires less monitoring than ECMO, but it does come with moderate to heavy sedation and can cause lung injury at high pressures or oxygen concentrations. ECMO allows patients to be awake and moving during their treatment. By eliminating the breathing tube and ventilator, it removes a substantial irritation that drives the need for sedation. ECMO is not without its risks, but these have become more manageable in specialized centers. Texas Children's Hospital is fortunate to have on-site ECMO capabilities, with both the equipment and experienced staff to help a patient who needs assisted breathing, but can't take the strain of being on a ventilator. Texas Children's is an internationally recognized center of excellence for ECMO, with advanced experience in this field. For more information, go to texaschildrens.org. The prior health of the patient.
So what do you think? Cool video, right? But, so pretty much, so what I'm supposed to do is after I show you the video, I'm supposed to say, well, you guys are experts on ECMO and pretty much goes over everything and let's have a great day. But it doesn't work that way, correct? So it's very informative, but for a respiratory therapist, especially at the bedside or when you are on rounds or when you have an ECMO program, that video is not going to cut it, correct? So we need to know more about it. But I thought that was a very great video because the way they showed things, the graphics, the animation, basic explanation was very well done. But we'll dive a little bit deep into it. So it's very important to know the history, correct? And how it started, why it started, and where are we right now, right? So if you think about ECMO, very similar to a lot of things that we always hear, right? A lot of times we hear about ECMO and we're like, oh, this is something new. Or APRV, oh, that's something new. Oscillators, new. Well, unfortunately not, right? These were all things that have been taking place 30, 40 years ago. And either for some reason it died down, or at some point it plateaued out, and maybe it's been reintroduced, or it's picking up steam because of whatever the new literature is out there and the outcomes, or whatever the case might be. But anyway, regardless of what the reason is, it's very important to know the genesis of how things happen and why it happened. So the first ECMO machine looks like that, and it was called the Model 2, the heart-lung machine made by Dr. John Gibbons, who was from Mass General at that time. And what triggered him to come with a device like that was as a resident. So again, this is 20 years later, correct? So residency, 15, 20 years prior to that. He was taking care of a young woman who had PE. And a lot of time we know, when we think about whether it's ECMO, whether we talk about nitric oxide, we talk about oscillator, we talk about proning patients, we know all that's an adjunct therapy, correct? Right? Even if you talk about ventilation, it's something that you're doing to buy time. That's all it is. Whatever the underlying issue needs to be worked on either way. So the underlying issue needs to be resolved or should be resolving for you to see a successful outcome. So everything that you do outside is just buying time. So very similar to that, we know that there's certain disease process, whether you look at adult or in a neonatal or pediatric setting, there's certain disease process that you need time. And certain time, as long as you can keep the patient alive, things will go back to normal. However, the crucial point is, do we have time? And what can we do to get that extra time or bridge that? So in this case, what happened was this physician, Dr. Gibbons, was at the bedside looking at this patient who was pretty much dying from PE. And all he could think of was the patient was on a mechanical ventilator at that time, and then the concept of low volume and the toxicity, or if someone's on high O2, things were not there, right? So there was not much research on that. But the outlook didn't look too great, so you have CO2s growing up and the O2 sats and things like that. At that point, they didn't have saturation, but still didn't look good. And he just was looking at the jugular vein that was distending over here, and he was just hoping somehow if he could just take the blood, siphon it out, clean it out, and put it back into the body, he can minimize a lot of stress, right, that he's contributing to the lung or the heart, and in this case, the lung. And if he could buy more time, maybe he could have reversed that situation. So this was a thought that was in his head, but unfortunately, he could do nothing at that time, and the patient passed away. Well, that didn't stop him, so he continued his thought process. He worked on the ideas, he looked at different things, and that's how we ended up with that big machine over there. Now, there's no pointer here, but if you look at that column up there, that is a bubble oxygenator. So pretty much the old model, what you would do is you would send the blood and you would introduce oxygen, and it's pretty much like a can of Coke, right? So whatever you put in, you put oxygen or carbon dioxide, you shake it up and you hope things get aerated. A very similar concept, and that's how you would introduce oxygen or oxygenate the deoxygenated blood, which had its own complications because there was toxicity. It would denature the protein on the RBCs, cause excess bleeding, things like that. So it was a short-term process, so you cannot really sustain patient on that for a long period of time, maybe an hour or two at the most. But at least it was something better than what they didn't have prior, right? So that was the genesis of that. And then throughout the years, a lot of advancement were made on the ECMO machine, whether it's the technical component, whether it's management, whether it is the cannulization, or whether it's even purely a protocol, or having a protocol in place. So a lot of the credit goes to Robert Bartlett, who is known as the father of ECMO, and rightfully so, because a lot of the research or a lot of initiatives that came from him and his team contributed to what we have right now. A lot of the protocols, including the ELSO. So ELSO is an organization very similar to our ARC, right? So they have the Extracorporeal Life Support Organization, which was founded in 1989 by Dr. Bartlett. Now, again, when we always think about progress or we think about success, right? It's never one person, correct? We always talk about team. There's always a team behind it. Whether you are a leader, whether you are the frontline staff, there's always someone who contributed to you towards your success. And in this case, there was multiple team members, but primarily another individual who helped them was also Philip Drinker. So does that name sound familiar? Drinker, Philip? No? No? All right. So we have another class on mechanical ventilation, and in that we talk a lot about Philip Drinker. And the reason being, I'll give you a little hint, maybe not, depending on how the slides. The iron lung. All right. So this is a very famous picture that it's used throughout, or very, very frequently, most of the respiratory lectures, especially if it has to do with mechanical ventilation. And it shows this picture. It's a polio epidemic. Took place between 1930 and 1950. And that time it really pushed the iron lung, and it was very famous and used very, very widely now. So Philip Drinker was one of the founding members who pretty much tweaked and came up with an iron lung that really worked. So it was known as a Drinker iron lung, and later the Drinker fell off and it was more like iron lung, right? So he contributed, or he worked together with Dr. Bartlett and came up with these things. So that's a primitive lung. And if you look over, you see the nurse? She's helping you get a little cigarette. And, and if you think about it right now, pretty much that would be quality. You'll get fired, your license will be pulled, and then when you go home, you'll have a lawsuit, right? But things were different. Things were different. So it's like a paradigm shift, right? So someone's taking care at the same time, you can smoke and contributing to whatever it was. And that was the trend. So, it's funny now, but back then it was norm. But anyway, so that was Philip Drinker, just to give a perspective on who he was and how he helped. And eventually now what we use are these devices. So we went back from a whole gigantic looking item to something that's much more portable. And I just put pictures of two commonly used units. One is made by Levitronics, the CenturyMag, and McKay uses the Cardio Health. These are the two most popularly used ECMO machines. Very portable and very easy to use as well. So just an FYI. So throughout the years, so in between all that, from the time that it became from a big machine to something like that, there were a lot of research that took place, right? A lot of research, a lot of experimentation in different parts of the world. So I put a few of the most relevant one that we should know. So if you look at the first literature that came out, so this was, what year is this? I see it 1972. So we had another individual who was by the name of Donald Hill and Dr. Bramson. They had their own version of a bypass machine, and they performed an ECMO on a patient at that time was termed as shock lung syndrome, which we call now as ARDS at that point, right? So ARDS was not really known. There was something underlying, but we didn't know what it was. So anyway, and what happened, this was, again, a young male patient, motorcycle accident, put him on this bypass machine, and it was a success. They were able to turn him around. Again, not as easy as how it's done now. For example, when you read the literature, it tells you it took like 12 hours just to put the machine up. And I have a picture of it, and it looks like that. All right, so that was your ECMO machine at that time. Now, and the reason why I say that is because one of the issues was, remember the first picture I showed you that looked like a big oven, right? And it had the bubble oxygenator. So by that time, during this era, that's when they discovered, they figured out, you need some kind of membrane, correct? So very similar to your AC membrane, there has to be some kind of layer that kind of filters, or in other words, lets CO2 escape, or in other words, get cleared out, and we can add O2 without damaging cells. So there were so many things that came in between. So there were some folks, especially Philip Drinker, he used something like a silk screen that would kind of differentiate the blood and the oxygen. And then at that time also something was discovered, what we call silicone rubber, right? So silicone was again known to have a characteristic which would allow permeability of O2, and that was used in this machine. So anyway, just to give you an idea. So there's a lot of work that goes behind, and we should be very grateful to what we have these days, right? So it's important to know history and the evolution. And so in that case, at least if we go backwards, we know, are we going to what we were, or is it something new? But anyway, so that was the 1971 incident, first successful ECMO patient. And then Dr. Bartlett did the first ECMO on a neonate patient. This was in 1975. And at that point, they had to do a VA ECMO. And eventually, about 21 years later, 1996, I believe, this was the picture that was taken. And there you go. Okay? So, again, what I just showed you were some of the success stories, right? So, always don't think that, oh, yeah, that was great, and ECMO was always a successful thing to do, but not really. So in between, you also had trials like this. 1979, there was a big study done by a group of individuals, and what they had over here was, it was sponsored by the NIH. It was over a 2-year period. randomized controlled trials, happened in 9 centers and 90 subjects, where trialed on ECMO. And some of the criteria were that PO2 was less than 50, FiO2 100%, PPO5 or greater. And what they did was they placed the patient on ECMO and conventional ventilation, and the other group was purely on mechanical ventilation. So what they found out was there was no significant difference in the outcomes, so about like 10% give or take. And retrospectively, when they went back, and so it was not a successful trial in that sense. So when we look at some of the data and how things were done and why it was not a success, there were some flaws to it. And some of the issues I put it out there. One was a lot of the patients bled out a lot, right, because of the technique used at that time, or the incisions were too large, or the cannulas were not the right size, and the process itself was not fine-tuned. High pressures on the mechanical ventilation. So even though patients were put on ECMO, the ventilator management was terrible, right? So at that time, this is pre-ARDS, so it was still high volumes and high PEEP and things like that. And patients on an average were on mechanical ventilation for about 9 days or greater before they were placed on ECMO. So certain damage related to, let's say, like villi, right? We'll go over villi in a bit, probably happened already. So again, we did not do it early on in that sense. And there was no uniform protocol. So again, 9 centers knew that they had to place patient in ECMO, but there was no uniform or standardized protocol, how they would do it, what kind of catheters or what kind of intervention, what kind of checks, what kind of settings would be on each ventilator. So everything was kind of disarray in a bit. So anyway, so that was not one of the best, and it was done, and everyone said, look, we know it's not going to work, and that pretty much killed ECMO at that point. What brought it up to recently, what really put it up in the forefront was, again, in 2009, thanks to our little pigs over here, right? The H1N1 flu. All right, so this was another study that came out in JAMA, and it was done in Australia and New Zealand in 15 ICUs. Again, it was not a randomized controlled trial, so pretty much what they did was they looked at all the patients that had H1N1 or suspected H1N1, and then depending on what they presented. So if it was hypercarbia, they could not fix that on a conventional mechanical ventilator, refractory hypoxemia, high pressures, things like that. They would say, well, let's put the patient on ECMO, very similar to what we do a lot of time, even with high-frequency oscillators or APRV, right? We wait till the point we cannot do much on the regular conventional ventilator, and then we say, whatever, let's try it. What do you got to lose? So what came out of this was, if you look over here, they found out that the patients who were placed on ECMO, they had about 79% survival rate, and on the other end, the patient who did not, what 87% survival rate. So if you look at the statistics, you're like, oh, so 79, 87. But if you dig a bit deep down, if you look at this, the patients who were placed on ECMO were much more critical in that sense. So you were looking at younger patients. So the average age, I believe, here would have been somewhere in the range of 35 to 40. And if you look at the PF ratio, it's like 55. Right? That's bad. So again, the patients who went into the ECMO program were much more sicker, and they were, like I said, much younger patients. So again, the moral, in other words, or the summary or the consensus was, if your patients are much sicker, right, and the factor of being young really didn't matter much. But again, if they were much more critical, you had much more success of keeping them alive or turning them around if you incorporate ECMO. So that was pretty much the give or take. Around the same time, 2009, there's another study that came out in Lancet. This was done in the UK. And again, what they did over here was they randomized 180 patients, 90 each, to regular centers that did not have ECMO, but they were managed on a mechanical ventilator, or to centers that had ECMO, or in other words, what we call more like a tertiary kind of setting, right? And what they found out was folks who either were placed on ECMO or went to an institution where they had ECMO capability, the survival was about 63% compared to the 47%. So what does that tell you? Does that say ECMO is the way to go? Not really, but what it does tell you is ECMO does give you that opportunity to do things a bit differently. In other words, you can use it to help patients and have a higher survival rate. At the same time, what it also pointed was just sending in patients to institutions that are capable of handling critical patients, the outcome is much more better as opposed to the local clinic or the local hospital that does not have maybe a very competent team or maybe the latest equipment or protocols and things like that in place. So anyway, so overall, these were like much more positive, and the outcomes kind of said that, you know, ECMO does have benefit. So again, from there were so many other research and literatures that are out there, and from there it kind of took up. So again, a few of the terminologies that you might see, whether in your institution or if you read books, if you look at literature, that you're going to come off is like cardiopulmonary bypass, ECMO, ELS, things like that, LVAD and all that stuff. So again, the whole concept here is pretty much how can you support the body till it rests and heals and take the stress away. And in the meantime, when you do fix the deoxygenated blood, how is it being done? And we'll talk about that as well.